My name is Chukwuebuka Ugwu. I'm excited to share findings from my PhD research, which focused on developing and evaluating gender-responsive TB interventions for communities in Nigeria. This research was part of the Light Research Consortium, which was funded by UK Aid. Nigeria is one of the world's highest TB burden countries and the highest TB burden country in Africa. Every year, about 500,000 people develop the disease newly in the country. And in 2023, 71,000 deaths occurred as a result of the disease, and 30% of people with the disease were not diagnosed and therefore couldn't be treated. In Nigeria, men constitute the majority of those with TB in the country, but are also less likely to reach care in a timely manner. This scenario is produced by a mix of social and structural, including behavioral reasons, including informal work that is risky and puts them at risk of TB, masculinity norms that prevents them from seeking care from TB, stigma, and poor knowledge. I used a mixed methods research approach to address these challenges and find solutions. First, we did a desk review of the TB service data in Nigeria, which revealed a lot of gaps along the care cascade for both men and women in the country. Thereafter, we conducted a scoping review looking at 25 years of TB interventions across the world, and we found that the current TB interventions were mostly gender blind. In other words, missing the opportunity to tailor care to the specific needs of men or women. We conducted interviews with men, women, healthcare workers, as well as local TB stakeholders. And it showed that men experience TB stigma, lack knowledge about TB, and are pressured by the masculine norms in their environment, which ends up delaying their care seeking. Armed with this information, we then engaged our local stakeholders to co-create a gender-responsive intervention that was suitable for peri-urban contexts in Nigeria. This included male-led TB information dissemination and mobile chest X-ray screening conducted in male-dominated community spaces. When tested, this intervention proved highly feasible and very acceptable amongst the local populations. It led to marked increases in TB knowledge and significant reductions in TB-related stigma. The implications of our findings are really interesting. First is that we know for sure that gender-responsive TB care is possible, and that when care is designed, contributed to, and led by local trusted, influential actors in our communities, that it can significantly improve engagement with that care. Our findings are already contributing to conversations around TB policy in Nigeria, helping to scale up equitable approaches across the country. We found that achieving gender equity in TB isn't just about expanding outreaches. It's really about thinking differently about how we deliver services to our communities, how we shape services to ensure that they help overcome the barriers that have excluded people who have long missed out on the care they need, and reaching them to end TB in Nigeria and everywhere else in the world.